morning, everybody. Our speaker today is Dr. Zine Steenkamp. She's a clinical and radiation oncologist in private practice in Pretoria, at Kloof in Hazelwood, and Mediclinic Midstream and Kloof Hospital. She graduated cum laude from the University of the Free State and completed her specialist training in Bloemfontein, earning her FCRad Onc degree and MMed Oncology cum laude. With a deep passion for oncology, a field often feared by so many, yet understood by so few, Dr. Steenkamp is dedicated to walking alongside her patients and their families with kindness, compassion, ethical and academic excellence. She believes in delivering patient-centered care that is both ethically sound and evidence-based. Her Master of Medicine research, Cardiotoxicity in Breast Cancer, Are We Getting to the Heart of the Matter, was recently published in the South African Journal of Oncology. Dr. Steenkamp has a particular interest in lung, breast, gastrointestinal, and gynecological malignancies, as well as supportive cancer care and survivorship. Thank you so much.
Good morning, everybody. I just want to confirm that everyone can hear us online. Okay, so today I'm going to be speaking about non-small cell lung cancer, pathways, progress, and precision medicine. So thank you, Leanne, for the kind introduction. So everybody is usually put off by oncology, but I want to flip the switch from oncology to oncology and hopefully shed some light on non-small cell lung cancer today. So today we'll be exploring the diagnosis, staging, and multidisciplinary management. I'll be focusing on stage 1, 2, 3 of it's a very vast field. So I think stage 4 we'll tackle as a completely separate topic. If we look at the overview of non-small cell lung cancer, it constitutes about 85% of our lung cancers. Stage 1 to 2 constitute 30%, and stage 3 make up 20 to 35% of these patients. It encompasses a wide clinical spectrum from disease that is early stage and potentially curable to complex irresectable stage 3 and A and B disease. The management is complex and hinges not only on the histology, but also on the stage, molecular markers, performance status, lung function and cardiovascular health, operability, as well as individual patient preference. So if we look at survival by stage, 5-year overall survival by stage, stage 1A has a prognosis of 90% survival at 5 years, decreasing to less than 65% at stage 2. And then the prognosis of stage 3 lung cancer remains poor even in our modern era, with, as you can see, stage 3C lung cancer having a 5-year overall survival rate of around 13%. So in terms of pathology and classification, so we're still using the 2021 WHO classification of non-small cell lung cancer. And you can see it's broken up nicely into your adenocarcinoma and its different subgroups, squamous cell carcinoma, your large cell carcinoma, adenosquamous, and then your other rarer subtypes. I want our focus of this discussion to be the multidisciplinary input in terms of the management of early stage lung cancer. So an MET approach has demonstrated benefits at multiple levels of cancer care. And specifically stage 3 non-small cell lung cancer, there's data from randomized trials that have actually showed that a multidisciplinary team improves time to treatment and also improves survival in these patients. And it plays a pivotal role in providing high quality care and treatment, and it's recommended at key decision points along the care pathway, especially in those patients that require multimodality treatment. So as you can see, the outer multidisciplinary team is our core team, and then we also have our our inner is our core MVT, and then inside that we also have our supportive MVT. So I actually summarized this nicely into just where the different role players fit in. So from our core MVT, we have the cardiothoracic surgeon, who's important in determining resectability, making decisions based on the performance status and vitals, advising on how to to obtain adequate tissue and improving post-operative rehabilitation. The pulmonologist plays a key role in also advising on how to obtain adequate tissue, the procedural risk reduction strategies, managing comorbidities, and interpreting the clinical and radiographic findings. Histopathology is key in terms of providing adequate histology, criteria for substratification, and evaluating this specimen for the adequacy of further processing. I'm a clinical oncologist, so I do both radiation and chemo. That will come then. So the radiologist is also very important in terms of advising on safe radiologically guided biopsies and identifying options for local regional therapy. And then the oncologist comes in terms of determining the optimal systemic management, testing for sensitizing mutations, and also the anatomic staging and advising on patients that are able to undergo radiation therapy. So I think the question always is where to start. And I think as pulmonologists, you'll have a lot of insight into the screening, but I'm going to start where we have a patient with a high suspicion for lung cancer. The first step is to determine the extent of the primary, and that involves evaluating for potential spread, pleural, mediastinal, and other spread, and then assessing the likelihood of metastatic burden based on the preliminary CT chest that was done, clinical assessment, and then lab findings, normally a full blood count, chemistry, liver functions, and a calcium. So this is a little bit small here, but this box is actually from Up to Date, which just gives us some insight in the signs and symptoms when one would suspect metastatic disease. So if there's any constitutional symptoms, things like focal bone pain, neurological symptoms, also clinical examination if there's effusions, lymphadenopathy, hoarseness, hepatomegaly, neurological signs, soft tissue mass, Horner syndrome, and then obviously your laboratory tests. Then in terms of selecting an approach to imaging, this is also quite controversial, and there's many ways to skin a cat. So essentially, there is a comprehensive way and a clinically based way that have been described. The comprehensive way involves that once a patient has been diagnosed, to do a whole body FDG PET and then an MRI brain when there is either concern for brain mets based on clinical symptoms, or if the patient has stage 3 or 4 disease. An alternative is to a clinically based assessment where you do a CT and site-directed imaging based on the suspicion for mets. And there are pros and cons to each one. In terms of doing an upfront PET, you have a superior sensitivity to detect occult mets, which could possibly reduce unnecessary thoracotomies and the morbidity associated with that. But it also has a relatively high false positive rate and is associated with significant cost. On the other hand, if one looks at a clinically based assessment, it's a little bit less sensitive, and sometimes one needs to do additional tissue sampling for confirmation, and there is the risk that we miss potentially occult disease. So it's largely based on institutional preference and regional practices, and both of these approaches are there to target imaging in the most non-invasive way possible. Next, in terms of choosing our biopsy sites, I think it's just important that we have enough tissue for diagnosis, and that's where the pulmonologists and radiologists and histopathologists actually have to be involved early on in helping to decide which area we would get the most tissue for accurate histological evaluation. So just in summary, while I was doing research for this, I found guidelines formulated by the MEA. So this is the Middle Eastern African proposed guidelines, and they actually have quite sensible and practical recommendations where they take international guidelines and undergoes expert review, and then they take into account real life management, taking into account our financial and also medical aid burden. So here they say that for solid and sub-solid nodules, a constructed CT chest and abdo is recommended. For larger tumors, a visualized biopsy via bronchoscopy or an ultrasound guided biopsy through an EBUS TBNA is preferred, and then you can consider other mediastinal staging results. They send patients with suspected lymph node mets on PET and a negative EBUS or enlarged lymph nodes more than 1 centimeters. Those patients actually do need additional mediastinoscopy. So the whole process, just once again reinforcing, it's a dynamic process that kind of overflows. Your initial evaluation and diagnostic staging overlap with the start where you start building your treatment plan. So all of this needs to just re-emphasize kind of happening together. In terms of staging your lung cancers, it's important to know that the AJCC 9th edition is now out in terms of classifying and staging our lung cancers, which is an update from the previous AJCC 8th edition. So the TNM staging is important because it's used for treatment planning and prognostic processes. And this accurate staging is pivotal to determine curative eligibility and also guide choices regarding new adjuvant and adjuvant strategies. In terms of the AJCC 9th edition that's now replaced, it's just important to know the main differentiators is now there's a subclassification of N2 disease into N2A and N2B, and M1C, which is your extrathoracic mets in a single or multiple organ system, has been split into M1C1 and M1C2. I found this nice, just summarized guideline in terms of how things have changed. So one can see that this split between N2A and N2B disease has changed the prognosis for stage 2B disease, and N1 disease now has been subclassified as stage 2A disease. And so it's just a little bit more comprehensive. And here the differentiation between the M1 C1 and M1 C2. So this is very important, and coming back to the fact where staging really is the baseline of us as oncologists' future treatment decisions. I wanted to highlight this just to show that we're already on version 6 of NCCN 2025. So these guidelines are constantly changing and being updated. So it's important to go back and revise what is the latest and best treatment options for your patient. So now, essentially, once we've staged the patient, we'll be focusing on early stage disease. There's a few other things that need to happen: lung function tests, a pre-op assessment, accurate mediastinal staging, and molecular testing. So in terms of the pre-op assessment, I just highlighted this, especially because of all the physicians in the room. This is up-to-date classification. So they still use a diffusion lung capacity cutoff of 60% predictive value in terms of substratifying patients into low, moderate, and high risk. So your low risk patients, expected mortality is less than 1%, and they are expected to be able to go major anatomic resections, whereas your high risk patients, the risk for surgery is more than 10%, and these patients should potentially be discuss alternative options to upfront surgery. In terms of mediastinal evaluation, there's also a lot of controversy, but it forms a very important part of our staging evaluation. So because the absence of tumor involvement in the mediastinal lymph nodes is one of the most important prognostic factors in terms of determining is this patient a surgical candidate or not. And there are once again a few options. So for myself, I've summarized this into patients that have had a CT or PET that are lymph node negative. Mediastinal staging is still indicated if there are central tumors or if it's a T2, T3, and T4 tumor. It's controversial whether or not to do mediastinal staging patients with peripheral T1 tumors that have no lymph node involvement by both PET and CT. And here the jury is out in terms of some suggest that proceeding directly to primary resection is reasonable given that there's a relatively low incidence. Others say that they still offer pathological evaluation of the lymph nodes given the high risk of occult lymph nodes. So there was actually this article in the Journal of Cardiothoracic Surgery that said that in 6.5% of patients with a T1 primary had occult N2 disease, which is significantly upstages the patient changes in management. On the other hand, we have patients that present with lymph node positive disease on CT or PET. These do require pathological confirmation. So even if it's in one disease, so enlarged hilar lymph nodes, and the rest of the glioma appears clear. If the patient is clinically lymph node positive by FDG or PET, and the patient has an EBUS FNA, they should still undergo subsequent mediastinoscopy prior to surgical resection, given the high risk of occult lymph node disease. So just once again, re-emphasizing the importance of this. So if the lymph nodes are negative, primary resection would be indicated. If they are positive, the patient would benefit more from upfront chemoradiation therapy. Also, in terms of our pre-operative workup, molecular testing is the new hot topic in oncology, and it plays a very big role in our metastatic lung cancers, but also in our non-metastatic resectable non-squamous histology lung cancers. And in the interest of cost, once again, there's a debate, should you do a comprehensive panel from the start or just nitpick? And this is where an MDT comes in. In patients that are up to stage 3 disease, it's reasonable to do an EGFR, ALK, and PD-L1 to direct our further treatment options. And then I thought, before we get into the specifics of each topic, especially if there's registrars and so forth, just what is immunotherapy versus what is targeted therapy. So essentially, immunotherapy harnesses the power of your immune system to fight cancer cells more effectively. So it does one of two things. It either stimulates your immune system to work harder, or it teaches your immune system to recognize these cancer cells as dangerous to be able to attack them. It's important to know immunotherapy is a slow responding process, but it also has a longer duration of response because it takes time for that immune response to build up. This is just a little bit of guidance in terms of where your different kind of immunotherapies fall in. So essentially, you have your PD-1 and CTLA-4. So these are expressed on your cancer, on your activated T cells, and they bind to the cancer cell to result in T cell inactivation and preventing death. So if we block that, we allow for the recognition to take place. So your anti-PD-1 drugs are your atezolizumab and durvalumab. And then PD-L1 is found on your cancer cell itself. And that PD-L1 binds to the PD-1 on your T cells and disrupts the inhibitory signal, which enhances the immune response. So your PD-1 blockers are your pembrolizumab and nivolumab. So this is just the two kinds of immunotherapy that we typically use in early stage, their dosing and their uses, but we'll get to that in a little bit. And then in terms of targeted therapy, so targeted therapy targets a specific kind of mutation or receptor abnormality. So immunotherapy works on immune response and targeted on a specific receptor. So the idea is, because it's more specific than chemotherapy, it also has less side effects. So in the early stage non-metastatic setting, the two targeted therapies that we use are osimertinib, which is an EGFR mutation blocker, and we use it adjuvantly for 3 years. These targeted therapies are typically oral, whereas our immunotherapies are typically given intravenously. Alectinib is the other one that we use for ALK-positive mutations. So once we've done our workup and we can really confirm the staging of the cancer, we can now start deciding on treatment. So I'm going to break this up into stage 1 and 2, which I'm kind of going to group together. And then I'm going to put stage 3 as a whole topic of controversy on its own. So stage 1 and 2 disease is typically disease that is limited to one lung, not involving the mediastinum or any distant site. And in this setting, surgical resection forms an important part of the treatment, but stereotactic radiation is also an alternative choice. So for stage 1 non-small cell lung cancer, if it's peripheral stage 1A or B, that can be completely resected with a lobectomy or less, we typically can proceed with upfront surgery. If it's central or requires more than a lobectomy, an NVT discussion is necessary to discuss is induction chemo indicated versus upfront surgery. Those that are inoperable either due to medical conditions or technical feasibility, definitive radiation, and there we prefer stereotactic radiation for these patients. For stage 2 disease, induction chemo and immunotherapy is now preferred, and this is followed by surgery. This is shown to have an improved event-free survival versus just neoadjuvant chemotherapy alone. However, there's no data to really inform neoadjuvant versus adjuvant therapy. And in a patient that's upfront resectable, it's not unreasonable to start with surgery and give chemotherapy adjuvantly. So in stage 1 or 2 disease, those who have proceeded directly to surgery, we need to decide, do they need any adjuvant treatment? So adjuvant therapy is not indicated for stage 1A disease, but it is or may be indicated for high-risk stage 1B disease. So this is also where a differentiator has come between the 8th and the 9th edition. So tumors that are exactly 4 centimeters remain stage 1B. Those that are more than 4 centimeters are now classified as stage 2 in the new AJCC classification. So high-risk stage 1B would be those tumors that are 4 centimeters or more, have lymphovascular invasion, are poorly differentiated, or on PET have an SUV of more than or equal to 10, and stage 2 disease. Post-operative radiation in stage 1 and 2 disease is only indicated if there's positive surgical margins. So this is just a nice pooled analysis of what is the benefit of adjuvant chemo in stage 2. So it reduces the risk by 5.4%, and this increases as one goes up in stage. That feels like a little, but if you look at the poor prognosis overall, that really has a meaningful survival benefit for the patient. In terms of what we use for adjuvant chemotherapy, we typically use a cisplatin-based regimen and combine it with a third-generation cytotoxic agent. If it's a non-squamous histology, for example, adenos, we prefer to combine cisplatin with pemetrexed. If it's a squamous histology, we have options of either vinorelbine, gemcitabine, or docetaxel. We prefer cisplatin over carboplatin just because it has a more robust demonstration of an overall survival benefit. But we can use carboplatin if there's baseline hearing impairment, existing neuropathy, or the patient is unable to tolerate the immunogenicity of the cisplatin. And another important question is when to give the adjuvant chemotherapy. So the ideal time is within 8 weeks. And then for those patients in whom we plan post-operative radiation, so if they have positive margins, we first complete the chemotherapy and then give radiation 4 to 6 weeks after the chemotherapy. So it's just a nice summary of how we decide which combination to use. So our vinorelbine typically is associated with a lot of neuropathy. It has our highest incidence of neutropenia, and it's lastig in the sense it requires a central IV access. Docetaxel has alopecia, more neutropenia than gemcitabine, but less than navalbine. Can also cause pneumonitis and hypersensitivity reactions. Gemcitabine main side effect is thrombocytopenia. Pemetrexed is actually a very well-tolerated drug with a low incidence of febrile neutropenia, and it's also not associated with alopecia or neuropathy. In terms of adjuvant targeted therapy, as mentioned, if the patient has an EGFR mutation, we give osimertinib for 3 years, and this is after the completion of chemo. Or if they are ALK positive, completely resected, the tumor is more than 4 centimeters, or lymph node positive, we give adjuvant alectinib for 2 years. In terms of adjuvant immunotherapy after the chemotherapy, this is an option for stage 2 to 3, so this is a little bit overlap with our next stage, and we can offer the patients atezolizumab or pembrolizumab based on the atezolizumab. They need a PD-L1 expression of more than equal to 1%, tumor size more than 5 centimeters, and lymph node positive. Pembro is indicated irrespective of this, and in tumors more than 4 centimeters and lymph node positive. But this is international stage guidelines. If we look at our local medical aid funding guidelines, this is just important. It's not currently in the funding guidelines, but the targeted therapy is. For our higher plans, we can motivate, and for many of these immunotherapies, there is sometimes financial support. If the medical aid does fund it out of protocol, or the patient is able to self-fund. So just to give an indication, the Pembro per cycle, and this is every 3 weeks, is about 80,000 rand, and that excludes the chemo, the facility fee. So it's really, really expensive kind of treatment. Neoadjuvant therapy, like I said, is an option for patients that are potentially resectable, but the studies are underpowered. There is a meta-analysis that showed an overall survival benefit for this. And NCCN says that you can give neoadjuvant therapy in those patients that would also warrant adjuvant therapy. So the most likely benefit is for those patients with node-positive disease or comorbidities that are being optimized prior to surgical resection. And then the regimen is the same as an adjuvant therapy. If the patients receive neoadjuvant chemo only, so no immunotherapy, you can consider adjuvant atezolizumab for them. So while I was just looking up, this is really hot off the press. This is up-to-date update from June 2025, which has now shown an overall survival benefit with neoadjuvant nivolumab with chemotherapy in your resectable non-small cell lung cancers that are more than 4 centimeters or node positive and lack a driving mutation. At this stage, nivolumab isn't available in South Africa, and we can apply for it, especially through Section 21. What's also new is neoadjuvant or perioperative immunotherapy. So this is where this neoadjuvant nivolumab comes in, or the perioperative Pembro, or the perioperative development. So I'll leave this on just for reference and for academic purposes. In terms of our surgical options, then one can either do a lobectomy. So this is what we prefer for most patients, and this can be via VATS or robotic or an open thoracotomy. For those patients with proximal tumors that can't be readily resected by lobotomy or require a more extensive procedure, we prefer a sleeve resection because it has equivalent oncological results and has better preservation of lung functions and without the complications of a full pneumonectomy. One can consider a sublobar resection, so a segmentectomy or wedge resection in those patients that are clinically N0 and the tumors are less than 1 centimeter in size. Older frail adults are once again need to be discussed in an MDT in terms of what would be the optimal benefits for them. So in those patients with early stage that are non-surgical candidates, we can offer these patients radiation. So radiation can either be via stereotactic radiation, and this is actually just a very high dose of radiation that's very conformal, image guided. The patient is well fixated with very precision targeting, and with that high dose, we have a very rapid fall off. So we don't have all that low dose spill to the rest of the organ. So that's just how it would look from our perspective, and this is how our conventionally fractionated radiation looks. So there's a lot more low dose spill, and we would look at the dose constraints of the different orbits to determine the feasibility of that. In terms of stereo versus surgery, so I've highlighted this very small trial, so difficult to infer meaningful benefits, but there is one study that showed that there was an overall survival benefits of 95% versus 79% for the patients getting stereotactic radiation. They said that this might actually be attributable to the better safety profile of radiation versus versus surgery. So those are just once again the MEA guidelines, which would say the same thing. And then in terms of my decision-making process, we decide the number of stereotactic fractions based on the size of the tumor and where it sits to determine if it's a single fraction or a multifractionated stereotactic radiation techniques. Now for the drama, which is stage 3 lung cancer. So many aspects of this treatment are controversial, and the data is limited because of heterogeneous patient populations in the trials, and the definition of stage 3 has changed over time. So essentially, what I've summarized is the patients can be split into EGFR ALK, so mutation negative and mutation positive disease. So mutation negative, you can offer induction chemoimmunotherapy, perioperative chemoimmunotherapy, upfront surgery, and then adjuvant systemic or definitive radiotherapy. For the EGFR ALK positive patients, surgery followed by adjuvant systemic therapy is preferred rather than induction or perioperative systemic therapy. So going through everything, I tried to summarize 5 big groups of stage 3. Stage 3 isn't just one disease, and I'll go through each of them briefly. So first we have those patients that have T3N1 disease. So just remember that the tumors more than 5 centimeters are now classified as stage T3, and if they're N1, this becomes your stage 3A group. So if they are mutation negative, you can offer induction chemoimmunotherapy or perioperative chemoimmunotherapy followed by surgery if that would be feasible. If a complete resection is not technically feasible, we would offer these patients definitive concurrent chemoradiation. The exception is those patients that have superior sulcus or pancreas tumors. And for them, chemoradiotherapy is preferred before surgery. And I think it's due to the high incidence of neurological complications with the Horner syndrome and so forth. Then you have your stage 3 disease consisting of multiple tumor nodules. So if there are ipsilateral nodules in the same lobe, these are patients who are candidates for induction chemoimmunotherapy or perioperative therapy. If there are ipsilateral nodules in the same lung but in another lobe, but negative mediastinal nodes, they may be candidates also for this approach, but it would depend on the location and extent. Solitary nodules in a contralateral lung are actually considered stage 4 disease. The studies have shown that these patients may actually have synchronous primaries, and these maybe have a favorable outcome if you treat each primary on its own merit separately. The patients with T4N0 to N1 disease, so this is unlikely that these patients will be surgically resectable. So most of these lesions, we prefer to treat them with definitive chemoradiation. There's a small subset that are surgical candidates. Preoperative induction chemoimmunotherapy may be of value. So once again, MDT discussion. But surgery is definitely contraindicated if there's N2 involvement or an incomplete resection is ultimately inevitable. In terms of those patients that are clinically stage 1 or 2 and then at surgery are found to be pathologically stage 3, like I said here, the jury is also out. So despite careful preoperative evaluation, including endobronchial ultrasound and mediastinoscopy, 20% of these patients actually end up having mediastinal lymph nodes. So adjuvant systemic therapy has demonstrated an overall survival benefit. The question is, should these patients get post-operative radiation? So some say no, unless the margin is positive, and this is in line with ASCO's guidelines. Others will offer it if there's other high-risk features. So these high-risk features would be multi-station node involvement, if the subcarinal lobe is involved and it's upper lobe cancer, if there's extranodal extension, if the highest node resected is involved, or if there's an inadequate nodal resection that will stop. Then we get those patients that are upfront clinically N2 or N3. MVT input here is very important, and the factors to consider here are the extent of the primary and disease, the ability to achieve a complete resection, as well as the patient's overall condition and preferences. And I've split it here into N2 and N3. So for N2 disease, most patients we give concurrent chemoradiation alone. This is with platinum-based chemoradiation, and then if the EGFR negative, we give adjuvant durvalumab. If EGFR positive, adjuvant osimertinib. For some patients, we can offer induction chemoimmunotherapy followed by surgery. So the patients that will benefit from those are those with a single station N2 disease that is less than 3 centimeters, and this is prior to induction therapy. Those that can be resected by a lobectomy rather than a pneumonectomy, or those that have responded to induction therapy with a complete clearance of the breast. Contraindications to this approach would be those patients that have a borderline performance status, poor pulmonary function, active heart disease, progressed on induction therapy, had extranodal extension, T4 disease, or multi-station N2 disease. With regard to our clinical N3 patients, these patients need definitive chemoradiation without surgery. So previously, there were some studies that examined sequential therapy, chemotherapy, then radiation to avoid the overlapping toxicity. But the superiority of the concurrent approach has been consistently demonstrated. And these patients also then benefit from adjuvant immuno and or targeted therapy. And then just some archaic approaches or approaches that are not routinely used anymore. So is induction therapy. So that's chemotherapy prior to chemoradiation. But it may be useful in those patients where we cannot safely encompass the tumor in a safe treatment portal without causing unacceptably high risk of pneumonitis. Or if, and it shouldn't be pursued and given the increased risk of toxicity. And there was actually a large phase 3 trial confirming this. Also, consolidation chemotherapy after full course of cisplatin-based chemotherapy and radiation hasn't demonstrated an overall survival benefit and is actually associated with toxicity. However, after the concurrent chemoradiation, we do give 2 cycles of chemotherapy for those patients that got weekly carbopacly, because that weekly carbopacly dose is considered to be insufficient. So this is just to say stage 1 to 3 is really just the tip of the iceberg, and stage 4 and all its targeted therapy and new novel therapies there is really a whole other ballgame that we'll leave for next time. So those are just my references, and thank you for your attention and your time.
Thank you. Thank you so much. It's quite very good insight into presentation of this on the perspective of the treatment of lung cancer really, and how do you, I think that's the condition we struggle with that, because that's where oncologists come in. We are more really for the diagnostic part of it. But yeah, I think it's now for the last 5-6 years, obviously immunotherapy become like the key corner of the treatment with actual better outcome than actually the previous the conventional therapy. But also what's become quite really outstanding was that the problem in our context in South Africa, most of our lung cancers are diagnosed too late, not quite early. So we have more people having stage 3 to 4, actually. But with the, I remember having a patient that had a brain mass, but he did very well on the targeted therapy. My point is that I think regarding the targeted therapies or immunotherapy, they're quite new in the market. And obviously, I think most of the side effects are not really well known in terms of the long term. And I've quite seen one of my patients that actually she did very well, but now she is struggling with the bronchiolitis of Midstream, what called Kloof. How frequent do you see that in your practice?
So the immune-related side effects, unfortunately, they are rare, but if they are there, it's quite severe. So the most common side effects that we see is immune-related fatigue, and then the colitis, and also the range LFTs. Pneumonitis is there, but I think it's unfortunately one of those things that one fails to recognize, one attributes it to a lot of things, and one really has to have a very low threshold to pick this, to suspect it and to manage it. And then also I was listening to another talk recently in the week as well, in terms of how do you stage, or how do you do a pre-assessment for these patients to possibly predict it and to monitor this. So that's perhaps something that we can work out as a protocol for ourselves.
Yeah, I think in terms of the pneumonitis, what we call drug-induced pneumonitis, we seem to have few. I think one was with melanoma, but normally those are really quite very good. They do respond to steroid higher dose, and they do very well. The bronchiolitis obliterans unfortunately become very difficult to treat because then they become a progressive disease, and they really kind of struggle with that because if they spend a high dose steroid, they don't do very well. The other things just want to ask about the role of PET scan in the context of obviously of the metastatic workup, because our experience was previous that you stage patient based on the PET scan, and you find that actually give you a false stage. That's every local case stage is quite lower down, but obviously when you go surgical, you find that actually there's more glands, more cancer everywhere, and when you find that you're really opening the patient thorax, now you're kind of stuck. You end doing pneumonectomy, but then you find that actually it's a stage 4. What do you think, or what's your insight about that?
I think, so first of all, I have two comments. I think some lung cancers are really rapidly progressive, and we sometimes wait a long time for authorization. So once a patient is diagnosed with a cancer, we first need to register them for an oncology benefit, which 3 to 5 days, then get authorization for PET, which can take another 3 to 5 days, and then get a booking, which can also take another week, which can defer and 3 weeks in a cancer patient is a lot of time for progression. So that's my one comment. The second comment is to remember that PET is very accurate, but it's insensitive for anything that's less than 7 millimeters. So anything that's microscopic, you won't, or not even microscopic, less than 7 millimeters, you won't pick up on a PET scan. And we see that with our melanoma patients as well. So some people do a PET and then they say the PET is clear, there's no need to do a sentinel lymph node biopsy. But it is, because a sentinel is based on, we're looking at sub-millimeter disease. So I think my advice would still be to do a PET scan, but maybe have a coordinated approach where that can happen quickly. And then, as I mentioned, even if the PET is negative, there's still indication to do, based on the risk stratification, surgical staging of the mediastinal nodes before proceeding with surgery. So I think, for us as a team to work out a workflow, they would be very important.
Yeah, I think a matter of comment about regarding the doubling time of lung cancers. Actually, I think because when you talk about delay of 6 weeks, I just wanted to caution, because the program goes live on the podcast, and I think for 6 weeks is not good enough for the cancer to double. The normal cancer doubling is almost about 365 days, so we don't from 3 to 6 months. So if they delay this biopsy everything 6 weeks, I don't think that will have more impact on the patient life, or actually even for the cancer progressing. The question that I think 6 weeks is not good enough. So I don't think delay of 6 weeks is something that we should really get concerned of, because it's just procedural. But I don't think that anybody got delayed for 6 weeks, that means the cancer has progressed, become metastatic, but you change the stages. I don't think so, because what will happen that those patients, irrespective, means they already probably have organ cancer somewhere, but it was not picked up on your PET scan. Then after 6 weeks, when you do, maybe they become obvious. We have seen that with breast cancer, where actually initially you have a completely negative stage, everything resected, only to 20 years down the line, you now have a new metastatic disease. It's just because of the doubling time is very slow. And I think probably that's more accurate words than that. But it's not actually probably not clinician delay that actually causing the misdiagnosis. But I think PET scan, as I say, it also depends where is it done, or who did it, and who actually interpreted it. And I think for me also what the doses of FDF that you use, actually, FDG that you use actually, I think those play a quite crucial role on that. Yeah. So I think, yeah. So I think for the people out there, it's not the 6 weeks delay. Please know those who are oncologists or clinicians for that. Definitely that's not the case. But I think it's just maybe your cancer's metastasized a bit earlier, but maybe not visible that for a diagnostic time, not available on X-ray. But maybe 6 months, it's 8 months down the line, it might become visible. So it means our test sensitivity is not strong enough to pick up actually those lesions at that particular time.
So that subclinical disease just comes to the forefront.
Yeah, I think that's the right thing. And then, of course, just the last questions. Of course, I think the stages you really quite highlighted very nice stages. I think our fellows, I don't know whether they're probably having lectures, couldn't join today, but I think the staging always become crucial in terms of the stage, because initially up to stage 3A, based on the TMM classification, the ideally was the tumor was resectable, everything looked like lovey-dovey. But now if you look at the stages, that's coming quite a bit lower down, isn't it?
Who should be screened and how?
Thank you. Okay, so I think obviously, I think any smoker. So what we have in pulmonology, we always do what we call low-dose CT scans, which is quite approved. And I remember that SATS, the South African Thoracic Society, actually issued guideline together with the conjunction with Discovery that actually clinicians are allowed for smokers who have smoked for more than, I think, 25 years history. I stand to be corrected on that. That actually can't benefit from the low-dose CT scan. Okay, and that now Discovery pay 100%, also perhaps also third other medical aid. So ideally, screening is more powerful than anything that. And I think on our setting, obviously, let's say clinicians, physicians, obviously, when someone's heavy smoker, I think low-dose CT scan will be the accurate one, and it's very inexpensive and it's rapid and give you accurate results. And if obvious that you have a single pulmonary nodule, let's say whether it's solid or semi-solid, and obviously depending on the size, it's a room of repeating in 6 months, 9 months, and obviously 12 months to have follow-up. But I think maybe we will put a lecture, me or Dan Joseph should be able to do a lecture on the single pulmonary nodule. Or perhaps we could do one tomorrow.
From the physician point of view, I mean, we have a lot of patients coming just for a overall medical. And I mean, what's the point of doing your mammogram, your bone density, all of those kind of preventative things and general screening tests, and then you ignore the lung, and we know lung cancer is quite.
I think it's very important. I think I still maintain to the fact that nobody die and go to heaven. They die because something was failing you. And as our role as a clinician is to find actually to delay that death from happening. And that means we have to screen a patient much more earlier before actually tragic struck. And that's mean obviously that you're right. As long as you do also bone density, you do breast mammogram. Anybody who is a smoker deserves also have his own the low-dose CT scan of the lungs. And obviously, I think I always even say the carotid, you have to look for it.
Even the cardiovascular, we try to be proactive in finding coronary stenosis and all of that to try and catch it before an event happens. And I think the cancer screening is also kind of part of that.
Yeah, I think you're absolutely spot on, Leanne. And I think for me, it's something that we need to kind of be preemptive, make a diagnosis much more earlier than actually you wait, And obviously, it's not one-sided try to look for all, but you have to automate your brain to be able to look at the patient holistically. And I think that's what physicians should be doing actually in quite more. I think maybe next discussion, if you could actually maybe one day to have a discussion about actually the screening, what are they actually looking at them, sensitivity, positive predictive value, and all those. Because at the end of the day, if you have to look at cancer, obviously we need to colonoscopic endoscopy, but also I always say you must look at pancreatic cancer, which could be very difficult. We also don't screen for that. We've seen that a lot in our setting, that always when they come just late, I think we also have to kind of see when we have to diagnose. So most of the time, I think most of my patients, I will try to do CT scan every 3-5 years, looking for pancreatic lesions, because the tumor markers become unreliable from age of 75, they tend to become mildly positive. So it's not reliable, but also if they have an underlying lung disease, also can be positive. So I think maybe screening tool would be the best thing that we should actually encourage our society, our people, our GPs, everybody else to make sure to get involved in that. Now, coffee?
Thank you very much, everybody.